So the first thing is how to make ACE-AED diagnosis. So in front of which symptoms do we need to think about those? This picture, I think it symbolizes a lot what's happening is that usually the patient will not have a lot of symptoms when he's in front of you, because maybe he will not consult you when he's in crisis, but inside there can be inflammation which can be visible or invisible. So that's, I think, something very difficult in those diseases. It's something which is not always visible, but it can be burning inside, or it can be cyclic burning with cyclic fever. So there are some elements in favor of ACE-AED. Some positive features with the timeline. So for adults, we always say that it has to have been begun 6 months before. Of course, it's different for children, because we don't wait for 6 months to think about those diseases when they begin very early in life. And then usually there are recurrent attacks, especially with fever, but some patients don't have always fever. And then something very important is that fever is not naked. And the three main systems that are involved are the skin and the mucous membrane, and we will see some pictures, and then the musculoskeletal system, the digestive tract. And one very important thing is the biological signs with biological inflammatory syndrome in crisis. And as my colleague just told you, there are some very rare diseases which are called interferonopathy. In those diseases, the inflammation can be very, very low or absent, but in the most common autoinflammatory disease, especially familial medical fever, there is an important inflammatory syndrome in crisis. So these are the positive features, but there are also some negative features. So the patients have no infection, no chronic infection, no neoplasia, almost no antibodies, and almost no immune deficiency. I will not go in the details because some of these are very, very rare, but I said almost because a very few of them can have some antibodies and immune deficiency. But I think we have to keep in mind some important advice, and the most important is that there is usually no antibodies and no immune deficiency. And then something very important is how to think about those diseases is to check out the timeline of the patient. So on the left side, you can see a baby or a child. So I will maybe my colleagues who are two pediatricians will speak about that after, but I think in a baby or a child, you can evocate those diseases quite early, even if the baby is only 1 or 2 months old. Whereas in an adult, so the right part of the slide, and this is my specialty, we usually take a 6 months delay between the onset of symptoms and the possibility to evocate systemic autoinflammatory disease, except for one, which is adult onset still disease, which can be very explosive, and we can evocate this disease much earlier than 6 months when the fever arrives. Then we were speaking about fever. So fever is one of the most frequent symptoms of the disease, and it can be seen like this. The curve I show you. So it can be recurrent fever with in between the episodes the patient has no symptoms, or it can be recurrent fever and a chronic background of clinical or biological inflammation, which means the CRP, for example, can either be elevated in between crises or come back to the normal in between crises. So the three main organs I told you about are the digestive tract. So we will speak a little bit about later. So you have a patient with fever and or recurrent fever and digestive symptoms, the cutaneous or mucosal symptoms, and I put here an example. So on the right you see the skin, and on the left I wanted to show you the oral aphthous that can be also bipolar, but oral aphthous are quite frequent in those diseases. And then the musculoskeletal symptoms, which can be located on the joints and or muscles. We were still in this part, which is how to think, how to evocate ACE-AED. Another one is, I don't know what my patient has. it's an enigma. I don't understand the problem, but there's inflammation. So then you can evocate systemic autoinflammatory disease. Another situation is this one, is you tried so many medicines and neither of them is working. It means you miss your target at each time, even though you have tried many different possibilities. And usually it means that classical medicine are not effective, and maybe it's because you haven't tried one target on, for example, IL-1 or interferon, just as my colleague told you. Some clues that are very interesting is the familial transmission. So whenever you have a patient with an enigmatic symptomatology, I advise you to draw the familial tree and to look for autosomic dominant transmission, just my colleague told you, or for consanguinity, which can be evocative of recessive disease. And another very important feature is when you have a patient, usually an adult, hopefully and luckily, with AA amyloidosis. So the most frequent way to diagnose AA amyloidosis is a nephrotic syndrome, and then there's a biopsy which is performed. And here on the left, you can see a glomerular biopsy with the staining against SAA, which is a specific, it's an unspecific inflammatory biomarkers. But when there is a SAA staining in a patient with amyloidosis, it is in favor of AA amyloidosis, and it can reveal an autoinflammatory disease.